Ulimwa Wellness Consultancy with 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 two patients today, and the first patient is 20. This is in Kante Hospital where the following scenarios occur at the Kante Hospital where you are employed as that hospital's chemical dependency expert. You have only one bed available and two patients have been referred to you for trick and admissions. The first patient is a 26 years old heroin addict. He has all the symptoms of withdrawal. He has a runny nose, stomach cramps, dilated pupils, muscle spasms, chills despite the warm weather, elevated heart rate and blood pressure, and a slight temperature. Aside from withdrawal symptoms, this man is in fairly good physical shape. He has no other adverse medical problem and no psychological problem. At first, he is polite and even charming to you and the staff. He is hoping you can just give him some meds to tide him over until he can see the regular doctor. However, he becomes angry and threatening to you and the staff when you tell him you may not be able to comply with his wishes. He complains about the poor service he has been given he has because he is an addict. He wants a bed and meds. And if you don't provide one for him, you are forcing him to go out and steal and possibly hurt someone. Or he will probably just kill himself because he can't go on anymore in his present misery. He also tells you that he is truly ready to give up his addiction and turn his life around if he is just given a son, some medication, and a bed for tonight. The second patient is an older man in his late 60s and is a bit disfigured appearance. He is accompanied by his landlady. The landlady tells you that she found him earlier this evening trying to enter his apartment door. He was sweaty, his eyes his eyes were dilated and his hands were trembling so badly that he could not get the key in the door. He kept calling her by another name and saying he was trying to get into his office to do some work. She knows he retired years ago, has lived in her apartment for several years, and knows her real name. His blood alcohol level is low and his speech is not slant. He can correctly identify himself but also appears confused. He is unable to tell you the month or season. His nose and cheeks are red with tiny spider fins, and his stomach distended, and when he extends his hand out in front of him, they are very tremulous. His demeanor is polite and apologetic to you and the staff. He tells you he has never had a problem with alcohol but scored high on the cage assessment test. He then admits to an occasional drink every now and then. He he did have a few drinks earlier today, but can't say exactly when. However, he is willing to come into the hospital for a brief stay if really though it was necessary. Then Question for cases 1 and 2. What preliminary axis 1 diagnosis would give ease of your patients and why? Use the DSM-4 to look up the axis 1 disorders and select one or two that best fit the ethical picture. What, if any, medical dangers do you see or should you consider for either patients and why? 3. What transference and countertransference issues would you expect to be present in working with patient A? What transference and countertransference issues might present themselves with patient B? Finally, based on all the above information, who gets the available beds and why? Remember, we have only one bed remaining in the hospital for addicts. In answers in case 1 and 2. In patient 1, the 26 years old is a heroin addict in withdrawal. His signs and symptoms all indicate opiate withdrawal. He has a runny nose, stomach cramps, dilated pupils, muscle spasms, chills despite the warm weather, elevated heart rate and blood pressure, and is running a slight temperature. He may or may not have other drug issues. A urine analysis may provide some answers to this question. Preliminary DX 292.00 opiate withdrawal or 304.00 opiate dependence. In patient 2 is in his late 50s and has all the signs and symptoms of a late-stage alcoholic starting to go into alcohol withdrawal. He was sweaty, his eyes were dilated, and his hands were trembling so badly that he could not get the key in the door. He kept calling the lady by another name even though he has lived in her apartment for several years. His blood alcohol level is low and his pace is slant, but appears confused. His nose and cheeks are lined with tiny spider fins. He has a distended abdomen, and when he extends his hands out in front of him, they are very tremulous. He probably does not have other drugs in his system like benzodiazepines. They would act as stabilizers and in his conditions, and these drugs are often given to treat alcohol withdrawal. Preliminary DX 291.00 alcohol withdrawal, delirium or 291.80 alcohol withdrawal. Patient 1, though he is in a good deal of pain and discomfort due to opiate withdrawal, patient A is not in any imminent medical danger. He is uncomfortable and will experience alternating cold chills and hot flashes. The cold chills produce a goosebumps, and how the term cold turkey came about. Painful stomach cramps, diarrhea are also part of the withdrawal syndrome and can be very unpleasant to be sure. Night sweat, muscle cramps, and muscle twitching is how the other term synonymous with heroin withdrawal. Kicking came into the lexicon. They are all part of the opiate withdrawal picture. Uncomfortable, painful, depressing but not fatal. Patient A is also exhibiting some classic drug-seeking behavior in which he is willing to say anything and do anything to get the drug that will give him some relief from his withdrawal symptom. When we come to patient 2, also appears to be in withdrawal from alcohol, However, because of his age, the probable length of time he has been drinking, and the potential severity of alcohol withdrawal, patient TB is in medical danger and should be seen by a doctor immediately. The dangers are delirium tremens or DTs. The symptoms are as follows. They begin with the anxiety attacks, increasing confusion, poor sleep, marked sweating, and fleeting hallucination or nocturnal or nocturnal illusion, which allows fear. Some patients may suffer grand mal seizures, several in short succession. There is a trembling of the hands at rest, sometimes extending to the head and trunk. Walls are falling, floors are moving, and rooms will be rotating. Injuries often occurs because patients are unable to maintain their balance at this stage. This force can cause severe head and neck injuries. Animals' hallucinations are frequent and often incite terror. It is also typical that in these delirious, confused states, the person will return to habitual activity, usually work related. In this case, patient B is imagining himself back at work and trying to get into his office. When we come to question 3, transference and countertransference are terms first used by Freud to describe anticipatory responses to situations that resemble or seem to resemble the original conditions that first gave rise to these behavior patterns. It is the unconscious basis for all human relationships. Some school of psychotherapy narrowly define transference and countertransference. Others see the phenomenon of transference operating on all levels of human relationship, both conscious and unconscious. Given these parameters, you can see that the transference expectation from clients to counselor are likely to be: for patients 1, negative, disapproving, and rejecting by staff and counselor. His likely behavior will be to first present as the good patients and to try and manipulate the medical staff into giving him some drugs to relieve his withdrawal symptoms. In fact, this is very appropriate behavior and should not be negatively judged for this behavior. To see his behavior from this vantage point can help reduce staff countertransference. This brings us to the countertransference issues regarding staff. Given patient one's manipulative behavior, first seeming to be in compliance and then becoming angry and hostile to staff, most certainly cause staff and counselor to unconsciously punish patient A. It is often helpful for counselor and all staff members to keep this in mind and not get put into the negative transference phenomenon. With regard to patient 2, here you have a person well into his retirement years. He may see you and your staff as too young and inexperienced to help him. A difference to treatment. He may feel embarrassed that he is being seen in such a state, or he may also transfer misgiving he has at either not having children or redressing perceived loans to the children he has lost or lost contact with. So, numerous layers of transference are all possible with regard to patient TB. Countertransference is also allowed in this case. Patient 3 can easily be perceived by the counselor or staff as a kindly old man. Lays the spectre of one's own family of origin, further countertransference. If positive, the patient gets very nursing care. If negative, the patient gets average to below average care. The final decision is who gets the one available bed. It should go to patient 2. He is more serious of the two and in greater medical danger of alcohol withdrawal. He is exhibiting all the signs of delirium tremens that in a person of his age and medical health could be fatal. While you should not minimize the discomfort of opiate withdrawal. Patient 1 is not in severe medical danger. It would be appropriate to refer him to an outpatient drug detoxification program or residential socio-model recovery program. This is Julie Moore, Wellness Consultancy, talking about standards of people with substance abuse problems. Welcome. This is Mulela. Mulela is in Delta is in Juja, Juja is in Kiambu, Kenya, in East Africa, in Africa. Comment to my video, like my video, and subscribe so that we can work together. Thank you.